This is a subject that we are paying a lot of attention because I have the feeling that during the first 72 hours, we know a little bit better what should be done. But then when we go to the phase, which is the longest phase for patients with ARDS, typically a patient with ARDS spends 48 hours during controlled mechanical ventilation, 48 hours during weaning, and then you have the big period of 10 to 14 days in which you are kind of lost. And I have participated in many protocols of protective ventilation, and now I believe that this transition phase is where we lose the battle. I have just some conflicts of interest because of the EIT project that is supported by the government of Brazil and a small Brazilian company. I will start with this very specific point that Michael Quinto was talking about, which is driving pressure that we know is correlated with mortality. So what about the driving pressure generated during spontaneous breaths or during controlled breaths? I think this topic was covered many years ago by Didier Dreyfus in this very important paper where he coined the term volotrauma, which I don't like. I think it's a concept that created lots of misunderstanding in the last years. But anyway, in this particular paper, I like this concept because this is the normal level of permeability, and this is the normal level for lung edema, dry and wet lung ratio. And this is what happens when you have a very high driving pressure during positive pressure ventilation. This is the control group, in fact, because the animal had the thorax strapped. But interestingly, no one pays attention to this result of his paper, in which we have negative pressure ventilation, 0 of PEEP, plateau pressure is 0, but the same gradient of pressure is applied across the respiratory system. So you can consider that you have the same driving pressure. And this is another way of defining driving pressure, and we are going to talk about another definition that is also possible. But in this case, by having the same driving pressure, you have the same injury, if not more. And more injury here is just because you have increased venous return, and then the edema gets more prominent. And then, so there is no doubt that this is exactly what the respiratory muscles, they do for you, for your lung. And then from an experimental perspective, we should expect the same degree of lung injury during driving pressure generated by the ventilator or by the muscles. So how is possible to calculate driving pressure during spontaneous breaths? If I have a controlled situation, let's suppose I like this. I like to imagine that this patient is under pressure-controlled ventilation. PEEP of 10, plateau of 30, small tidal volume. I can easily calculate here the driving pressure, which is 20. But what about this patient that is under spontaneous ventilation? And then the concept of driving pressure suppose that I have no muscle effort, and then I'm measuring the gradient of pressure that the ventilator is producing, the oscillation in alveolar pressure. There is no solution for doing this during spontaneous ventilation because we don't measure how much of the volume is generated by the muscles, and then you cannot say anything. But you can do an approximation, and then we are going to discuss that this approximation is good enough for some cases, but in other cases, like the Pendeluft, it's not good enough. Anyway, this patient is under controlled mechanical ventilation. We make the reasonable hypothesis that driving pressure is tidal volume divided by compliance, and that the lung disease does not change from 1 minute to the next. It's very reasonable. and Jacopo Bellani showed us a very nice result showing that this is reasonably true. And then, okay, then the patient here has a driving pressure of 20. I can calculate his compliance is 18. And then I make the hypothesis that 5 minutes later, when the patient is doing some spontaneous effort on top of pressure controlled ventilation, now having assisted pressure controlled ventilation, now I know the tidal volume, so I can divide tidal volume by compliance, and then I have driving pressure, which is 30. So this is a very easy way of doing at the bedsides. If every day you know how much is the compliance, you can, whatever the tidal volume the patient is performing, you can more or less estimate the overall driving pressure of this patient. So the key factor here is to know lung or respiratory system compliance. This is the paper I was talking about. So Bellani was showing that this approach applied to patients under controlled mechanical ventilation or during different levels of pressure support is reasonable. You calculate elastic pressures, which is tidal volume divided by compliance, and if I have the same tidal volume in each of these conditions, I have the same driving pressure. So they used the esophageal balloon to get to this concept, but at the bedside, you don't need. If you have measured lung compliance, you are okay, and you just calculate tidal volume divided by compliance. But as many topics in medicine, this is a first approximation. And then after discovering the Pendeluft, we realized that this is a little bit more complex. And for instance, in this old paper of Takeshi, we applied these concepts of estimating the overall driving pressure promoted by the muscles. And then we realized that when we have just the ventilator and we have lung edema, now we add the muscle effort on top of this. Initially, you have an improved recruitment of the lung because the driving pressure is higher. And then you are having the same beneficial effects of high tidal volume ventilation. But then later on, you are going to pay the price because you have more lung edema. And then, so just a memory that whenever you have a higher driving pressure, oxygenation improved, like we had in this seminal ARDSNet paper, just looking the other way around. The protective arm is here with a very bad oxygenation during the whole week. Increasing tidal volume is very good for oxygenation, but later on in the second week, we know that these patients, they died more. So, so there is no question. Increasing driving pressure is by adding the muscles is going to improve your oxygenation, increase the tidal volume, and increase the effective driving pressure, and also the injury. But then it came the discovery of the Pendeluft, which was something that we are monitoring in some patients after cardiac surgery. And then we observed that when the patient was in a calm situation, ventilation was like this, very homogeneous, very, let's say, typically when the patient is under controlled mechanical ventilation, we either see homogeneous ventilation, or when the patient has very heterogeneous lung disease, you see the air going first to the upper lung and then to the bottom. Why the upper lung first? Because the regional compliance typically is in a better shape and the regional resistance is slower in the non-dependent lung. So whenever we are using low PEEP, I see more air going to the upper lung. But then in this particular patient, we started to observe this. And then first we thought that it was a technical defect of the machine, the EIT. How come that in an atelectatic lung, I have the first entry of air in the bottom part? This was very intriguing. And this is why we decided to do a lung injury model in animals to study this phenomenon. And then later on, we realized that this is consequence of the diaphragm activation, a very different way in fact, the diaphragm is doing what he does all the time. He's just contracting. But the response of the lung is very different because there is a very heterogeneous response. And then, in contrary to what we have seen in the last years, the first air goes to the dependent lung, even having lots of atelectasis here. And then I think Brian has already explained you this solid-like behavior. It's kind of a situation in which the diaphragm is exerting a concentrated force in the dependent lung. And then as a result of this, you have this big overstretch that you can detect by EIT, much larger, twice, 3 times the stretch that we see during controlled mechanical ventilation, especially in the dependent lung zones. And the surprising thing is that the tidal volume is exactly the same. So during the Pendeluft, you have overstretch, but the global tidal volume is exactly the same, 6 or 7 mLs per kilogram. So it's just a movement of air inside the lung. And it's interesting because when your patient is having Pendeluft, it looks like from the ventilator perspective that you have protective tidal volume. But in fact, what is going on is a zone of concentrated stress, and then the diaphragm is kind of is anchored to this part of the lung that is working like a glue, and then you have a preferential filling in this zone first than the rest of the lung. We put some sensors here, and to our surprise, you see that this zone that is very close to the diaphragm has a much lower, much more negative pleural pressure than what you can measure with the esophageal balloon. So the nice thing about this Pendeluft is that, first of all, that if you measure, you calculate the regional tidal volume in this region, it's equivalent to 15 mLs per kilogram. How do we know this? Because when the animal was paralyzed, we started to increase the tidal volume of the animal to the point that we see a stretch of the same magnitude in the bottom part of the lung. And to do this, we had to apply 15 mLs per kilogram. Typically, this zone happens here, where the diaphragm has the strongest concentration of forces. Now, we went a step further, because now we can monitor this online. How? Because we can calculate more or less which is the degree of stretch in the overall lung, and then we can detect that there is a zone in the lung, and typically in the dependent part, that is suffering much larger overstretch than the rest of the lung. And we can also calculate that while the rest of the lung is receiving, let's say, 6 mLs per kilogram, this zone is receiving an equivalent tidal volume of 8 or more mLs per kilogram. So I'm increasing my regional tidal volume by 30%. The next step was to prove that this caused lung inflammation. And this was true. We have now plenty of data showing that in the PET studies, these zones suffering regional overstretch, they are getting more inflammation in the PET. Remember that the typical pattern of PET during ARDS is not this one, it's this one. This is the typical scenario in a patient ventilated during controlled mechanical ventilation with 10 of PEEP. You have overstretch of the baby lung, which is typically non-dependent. And in our case, we have the opposite. We have overstretch in the zone that the diaphragm is concentrating force. You see the overstretch measured by EIT, and you see the inflammation in the PET studies. In this particular animal, the overstretch was equivalent to 14 mLs per kilogram. What we are trying to do now is that it's it's a kind of concept that is not easy to, because tidal volume by definition is global. So talking about a regional tidal volume of 14, it's a little bit confused. So what we are trying to do now is something a little bit different. In this original paper from Takeshi, we measure local pleural pressure, local transpulmonary pressure, using the sensor in the pleural cavity and airways. And here we measure the regional volume. So when we increase the transpulmonary local driving pressure, the difference between airway and the local sensor, we have an increase in the local stretch. It's very linear. So it looks like that the lung has the same compliance all over, the same mechanical properties, and the regions that they are suffering more stress, they have more stretch. So more pressure, more transpulmonary pressure, more local strain, which means that now that we can calculate driving pressure for the global lung, we can also calculate the driving pressure for the Pendeluft zone. For instance, in this case, the global driving pressure is 10, but this region is suffering equivalent driving pressure of 20. So these are some developments that we are trying to apply to explain these differences in regional inflammation. And so in a global sense, a higher driving pressure promoted by the ventilator or the muscles are always bad. But sometimes when you have this very heterogeneous lung behavior, like when you have the Pendeluft, you have to think about some regional phenomenon that is amplifying the global number that you see on the ventilator. Thank you very much.